Good evening. Hello to you who are joining us on the phone and for those of you viewing us on Facebook. Just to remind all callers, please remain on mute. This is not a town hall set up for questions directly from the audience, but if you're on Facebook, you can type questions in, and others may have sent in questions earlier. I should start off by introducing myself. My name is Liz Krueger. I'm the state senator from the 28th district, and you're with us tonight because you've chosen to hear Dr. Michael Niederman, who's going to be our expert presenting on information about COVID from a clinical perspective. So we're glad you were all able to join us, and we hope you are staying safe. Right behind me, out on my window, I hear the 7 o'clock revelers celebrating, as they do every night, our first responders. So if everybody wants to take a minute and give a yell, feel free. Just stay on mute when you do it. Remember, to stay safe, you always have to stay 6 feet between you and other people when you go outside to run essential errands, and wear a face covering. If you're using a cloth face covering or mask, it should be washed once a day and completely dry before you use it again. I know you hear this a lot. Continue to wash your hands a lot. Last week, Dr. Dennis Nash, a distinguished epidemiologist, kept repeating how important it is to wash your hands, and wash your hands for 20 seconds with soap and water is the best. I try to sing a song that I've calculated is about 20 seconds long when I'm washing my hands. I just want to remind people also to get an absentee ballot for the June 23rd primary. If you think there are any primaries going on in your district, you will actually now, as a New York registered voter, automatically get an absentee ballot application sent to you. If you fill that out and send it back, you can get an absentee ballot mailed to you. If not, we're still going to have early voting and regular voting on June 23rd. So I suppose one of the best ways to prove the resiliency of our country, state, and city is to show that we can move forward with normal democratic process and elections even when we are trapped mostly in our homes. There's also a new website for the June 23rd primary. So you can go to nycababsentee.com. nycabsentee, all one word, .com. And then if you want an absentee ballot, on the questionnaire you answer you're using temporary illness as the reason you need to vote absentee. You don't actually need to have COVID. The governor did an executive order saying we all get to treat ourselves as if we're temporarily ill because we have COVID everywhere, and that's the basis for being able to have an absentee ballot. To give you a quick overview of tonight's events, this is the second town hall of a two-part series, and we're going to be focusing on COVID-19 from a clinical medical perspective. I am thrilled to be able to welcome a renowned pulmonologist and critical care specialist, Dr. Michael Niederman, Professor of Clinical Medicine, Weill Cornell Medicine. Dr. Niederman will discuss clinical aspects of COVID-19, including how it spreads, the range of symptoms patients experience, and therapies that are being used to manage the disease. Before I introduce our presenter, please remember, keep your phone lines on mute. After the presentation by the doctor, I will moderate a Q&A. We have questions that have been submitted in advance, and you can still submit questions through Facebook. Now it is my pleasure to introduce Dr. Michael Niederman, who is the Professor of Clinical Medicine, Weill Cornell Medicine. Thank you so much for being with us, Doctor.
Well, good evening. Good evening, everybody, and thank you for being here. I'm going to share my screen with you in a moment and give you an outline of the things that I'm going to talk about. But I wanted to just take a moment to say hello, let you know that how difficult this has been for all of us, certainly for us as physicians, as well as, of course, all of the things that you are going through. This has just been a difficult and strange time. And my goal tonight is to talk with you about COVID so that hopefully knowledge will make you a little bit more relaxed and a little bit more of a sense of control over what's going on around you so that you'll be able to participate in your own well-being, the well-being of your family, and again, feel a little bit more reassured as you can be with knowledge rather than purely just hearing things that might be viewed as rumor and not really accurate information. So this is just my introductory slide to give you, again, my background and my interest. And in the lower right-hand corner is an email. If you write to me, I may be able to answer you. I may not, depending on what else is going on. But just so you know who I am. And let's see, I think, here we go. So the topics that I'm going to talk about are listed here. And I want to go through this somewhat systematically. I figure that I'll talk about 20 minutes or so and then leave time for all of you to ask questions. And I've tried to cover topics that I think would be important and of interest to you. And there's a second list of topics, so this is not all that I intend to talk about. So COVID is coronavirus illness, and this refers to a SARS coronavirus 2 that arose in 2019, and that's why we call it COVID-19. But we are very familiar with coronaviruses for many years. Coronaviruses are RNA viruses. They can often cause just a simple common cold, and probably many of you have had coronavirus infections in the past. What makes this particular coronavirus unique is that it spreads in a very aggressive fashion, and many patients have become infected, and at the severe end of the infection spectrum, patients can become very ill. We don't know that this disease is necessarily got a very high mortality, but it does appear to have a higher mortality than the flu, and the complications that we're encountering, again, at the severe end of the spectrum, are really quite dramatic, and we'll be talking a little bit about that. But the common symptoms of COVID are those of a cold. Patients get a sore throat, they get a runny nose, they may get loss of smell, fever is particularly common, and cough can occur. And so there's nothing very, very distinctive, nothing very, very specific. And symptomatically, it can look like a flu, it can look like the common cold, it can even look like allergies, although allergies, which are going to be emerging, particularly around this time of year, are a little bit different because allergies tend to be much more associated with itchy eyes and runny nose, where although you can get a runny nose in this illness, the most common symptoms, again, are sore throat, cough, and fever. Patients can have profound muscle aches, and some patients have described debilitating pain, and they can be curled up in bed from fever and chills. So it runs a wide spectrum. But what I think is important to understand is this disease symptomatically can go from very mild asymptomatic disease to more severe illness leading to hospitalization. And originally our thinking was that 80% of patients had mild or asymptomatic disease, 20% ended up in the hospital, and of those who ended up in the hospital, maybe 1 in 4 ended up sick enough to go to an ICU where they might need a mechanical ventilator. And that was the population that had the highest chance of dying. But if you ran through the numbers based on that kind of analysis, you came up with a conclusion that the mortality rate of this disease was somewhere between 2 and 3%. Now that's much higher than the flu, but that mortality rate calculation is based on a guess as to how many people are infected. And since we don't have very, very widespread testing, we don't know exactly how many people have been infected. It's been estimated more recently that there are many more people infected than we thought originally. And if the number infected is much higher than we originally thought, and the number who have severe illness is the same, then the percentage of patients who get infected and then get severe illness is much smaller. And so we're still trying to sort out exactly how many people have severe illness and what the true mortality rate of this is, but we do know from recent estimates that many of these infections are asymptomatic. It's been estimated that maybe as much as 20 to 25% of all people in New York have already been infected. And one of the things that's both good and bad about this virus, asymptomatic infection is a good thing because you don't get very sick. But asymptomatic infection can also be a very bad thing because during the asymptomatic period, we have learned that patients can shed virus. And so the incubation period, the time from when you're originally infected to when you become symptomatic, on average is about 5 days, but can go out as long as 2 weeks. And maybe by 10 days, 95% of all people have symptoms if they're ever going to have symptoms. But during that time that they're asymptomatic, they may be shedding the virus and spreading it to people in their environment. And when you're around someone who's not looking sick and they're spreading the virus, then you're at risk for getting infection unless you're taking precautions. And like Senator Krueger said, you do want to have social distancing and you want to be protecting yourself by hand washing and by wearing masks. And we're going to talk about masks in a little while, and I'll try to explain what that's all about. But the virus spreads person to person, and it can spread in the air, and it can spread by droplets. And in the air means that if somebody's coughing and they aerosolize the virus, or if somebody's talking and spitting little particles into the air as they talk, that aerosolizes the virus. And very, very small particles of the virus can remain in the air for maybe 2 hours, 3 hours. And if you're walking next to someone who's aerosolizing the virus, potentially you could be breathing it in during that time. Now, we think that just a casual exposure isn't enough and that you need to be within 6 feet and probably within 6 feet in contact with that person for maybe 10 or 15 minutes, but not just a casual exposure. There's also exposure by droplets where, again, particles come from the mouth, from the respiratory tract of somebody who's carrying the virus, and those particles spread in the air. They can land on surfaces, and they can land on your hand. So if you're talking to that person, if you shake their hand and they've touched their mouth or their nose, if you touch a surface where the particles have landed, and then you touch your mouth or nose, you can be transmitting the virus. And we know that the virus can live on surfaces. Cardboard and copper seem to be the surfaces where they last the shortest, maybe under 2 hours, but they can last 3 or 4 hours or even up to several days on plastic and stainless steel surfaces. So that becomes important when you think about the materials that you have to be particularly careful about. Boxes, for example, which are cardboard, sustain the growth of the virus maybe for a few hours, maybe up to a day. But plastics and stainless steel surfaces can sustain the growth of the virus for several days. And you ought to keep that in mind. So one of the questions that patients often ask is, what should I do when I get a package? What should I do when I get groceries? And if things are in paper, one potential thing you can do is just let it sit for a day before you open it up. The incubation period, as I mentioned, can be anywhere between 5 and 10 days. But the fact that patients shed the virus before symptoms start means that they can be spreading this virus when they don't have symptoms. The other part about spread that's important to understand is after patients get better, they can also continue to shed the virus. And the sicker they have been, the longer they seem to be able to shed the virus. So patients who've been in the hospital very sick, we know that they can shed the virus for as long as 2 or 3 weeks, or sometimes longer, after all the symptoms are gone. And as a general rule of thumb, we tell people that after you feel all better, you should wait an additional 2 weeks before you're exposing yourself to the general public. You should stay in quarantine for at least 2 weeks after all your symptoms are gone to minimize the chance of spreading this virus. One of the questions that's come up repeatedly has to do with testing for the virus. And I think there's a great misunderstanding about what testing is and what testing can do and can't do. So there, first of all, are two types of tests. You can be testing for the virus itself, or you can be testing to see if your body developed an immune response and has antibodies to the virus as a result of having had a viral infection. So the testing that you first saw, where people were getting swabs in their nose, is the test for the virus. There's a very sophisticated polymerase chain reaction, very detailed molecular testing method for the genetic fingerprint of the virus, and that's tested by swabbing the lining of the nose and the back of the throat, and that's called a nasopharyngeal swab, and that swab is potentially infectious. So when you go for that viral testing to see if you're currently infected, that virus has to be recovered from the nasopharynx. It is possible that you go for that testing and they don't get a really good deep sample. So that testing could be negative, and false negatives do occur depending on the quality of the sample, depending on the quality of the test, depending on how well they handle the sample. It's been estimated that up to 30% of the time, tests can be falsely negative. So if you're feeling sick and you've got all the symptoms of coronavirus and you get a test and it's negative, that doesn't necessarily mean you're not infected. And sometimes we have to repeat the test. But to me, it's much more important to decide to quarantine yourself and protect your family and your neighbors and friends based on your symptoms, not whether that virus test is positive or negative. On the other hand, the second test that we talk about is antibodies. That's getting a blood sample and seeing whether you've mounted an immune response to the virus and you've got antibodies against the virus. Those antibodies are really important because, as I'm sure you've heard, some people who have high levels of antibodies can donate their plasma, and that plasma can be given back to patients with coronavirus to fight the virus. It also means that if you have antibodies, you have some degree of protection against yourself getting infected by the virus. Now, we don't know exactly how protective the antibodies are. We don't know even right now how good the tests are. And I think we're going to be learning this more over the next few weeks, where we're going to have now multiple tests available. Some will prove better than others, and the reliability will prove better than others. But some antibodies will be highly protective, and that may mean that the people who have antibodies not only can give their serum to help others, but they're protecting themselves, and they're not likely to get infected again. So when we talk about reopening the economy, the first people who will be easiest to go out and open up the workplaces, the stores, all of the workplaces that you would want to go to visit would be people who've got antibodies, because at least if they're exposed to an active case of coronavirus, they're much less likely to get infected than someone who has no antibodies. In terms of whether you should get a test when you have symptoms, I'm not very sure that it makes that much difference right now. So I do think that when testing could have been done very early to allow contact tracing and controlling the spread of infection, it was a different discussion. But now that we have a lot of coronavirus in the community, it doesn't matter to me as a doctor whether my patient's test is positive or negative. If they've got the symptoms, I'm going to view them as having coronavirus regardless of the results of the test. So I think that you've got to think long and hard as to whether you really want to get a test, particularly if you have mild symptoms. Because if you go to a hospital to get a test, and when you went, it turns out you didn't actually have coronavirus, to actually get the test, you'll be exposing yourself to an environment and to people who probably do have coronavirus, at least more than you would have if you stayed at home. So I don't advise my patients to run and get a test when they have symptoms because it's not going to change my approach to them. I'm willing to manage them based on symptoms as if they have coronavirus, and it doesn't matter to me if the test is done, if it's positive or it's negative, knowing that a negative result can be a false negative result. So I think testing like that may be valuable if I have to know later on, but very rarely is that the case. What about managing yourself if you think you do have coronavirus? So let's say you have fever. We know that it's better to control that fever with Tylenol than with aspirin or nonsteroidal anti-inflammatory drugs like Advil. There's been some, not strong evidence, but some data to suggest that the usual nonsteroidal and aspirin-type drugs interfere with the immune response to the virus. Tylenol is probably better, and when you're going to take treatment for fever, you should be doing it around the clock. Not, I'll take it now, but like if you decide you want to treat fever, take the medication around the clock every 6 hours for at least 24 hours before you consider stopping it. The way in which you position yourself in bed at night might be important. We know that if you sleep on your back, you're much more likely to drop your oxygen level at night. Whereas if you sleep on your side or on your stomach, that allows more of the lung to expand and you can get better oxygen levels by sleeping on your stomach. That's referred to as prone positioning. There's been a lot written and said about that, but it's not so simple because there are some people who are so weak that if they prone position, they can't roll back, and that's not so good. So if you're going to do that, you have to be able to roll back, or you have to have someone with you who can help you roll back. And if you happen to if you're pregnant, or if you have a very big abdomen, you could actually push that abdomen into your lungs, and that could interfere with your breathing. So prone positioning is a good idea, but it's not for absolutely everybody. I like people to take deep breaths. I think that's a really good idea. Taking a really deep breath expands your lung and makes it harder for the virus to take hold and to grow and cause pneumonia. There was a very popular online video that J.K. Rowling of Harry Potter fame promoted where it shows a person taking 5 really deep breaths, holding the breath for 5 seconds, letting it out, doing it again, doing that 5 times, and then giving a really big cough at the end. I don't know if that really works, but it makes sense to me in many, many ways, and it's very much like the breathing exercises we tell people to do when they have lung problems with a lot of mucus. Drinking a lot of fluids is important. Remaining hydrated keeps your mucus thin so it doesn't get stuck in your lung. And an oximeter, I think, is a very good thing to have. An oximeter, if you've gone to the doctor, is that little device they clip onto your finger, and it measures your oxygen level. And when you're feeling a little short of breath, if you measure your oxygen saturation and it's above 95%, I'm not quite as worried as if it's down around 92 or 93%. So I tell my patients, if you have an oximeter, measure it. If you don't have an oximeter, try to get one. A lot of places are sold out of oximeters now. You can order them online, and that may take a while. But I know that on the iPhone, for example, if you go to the App Store and you type in oximeter, you can actually get an oximeter app for your phone. And what it does is it asks you to put your fingertip underneath the light, and it'll measure from the color of the blood running through your finger what your oxygen level is. And that might be helpful for yourself and for your doctor, figuring out when you are really sick and need to go to a hospital. There's been a lot of interest of self-management using medications. Plaquenil, which is hydroxychloroquine, zinc and azithromycin, which is an antibiotic, have been very popular among certain groups of people. They've read anecdotal reports about how these drugs are miracle drugs and prevent severe COVID. I don't know if that's true. Some of the recent studies suggest that Plaquenil may not be so safe, may have cardiac complications. And we do know that if you use Plaquenil and azithromycin together, they have a chance of interfering with conduction of electrical signal in the heart and may cause even more likelihood of cardiac complications. So I don't recommend people do that unless they're in a situation where their heart is being monitored. A big discussion has been masks. Should we be wearing masks or not? And I think it's really important to understand the types of masks and what they do and why we wear them. There's a surgical mask, which is not the tightest fitting mask. And there's the N95 mask, which is tighter fitting, and it filters the air so that only very, very tiny particles can get through an N95 mask. The N95 mask is for medical workers. I see a lot of people outside wearing N95 masks. I don't recommend it for two reasons. Number one, I'd like to see those masks be used by medical workers who are exposed to high-risk aerosols. But also, when a medical worker wears an N95 mask, we get fit tested. I know what size mask to wear. I know how that mask needs to be adjusted to give me the very best seal. If you put on an N95 mask, you may have the wrong size, you may not have the right fit. It might not do nearly as much for you as you think it is, and you may be falsely reassured. Surgical mask will cover you, and it will cover you. And the purpose that we want people to wear masks is twofold. Number one, if you're sick or the people around you are asymptomatically sick and everybody's wearing a mask, they're much less likely to spread it. So once everybody starts wearing masks, it protects everybody else. So when you see people who say, I don't want to wear a mask, I don't care, I'm not worried, that's not why I want them to wear the mask. I want them to wear the mask to protect me, not them. Protect me in case they have asymptomatic illness. Also, if you wear a mask and somebody gets droplets in the air and they land on the mask, that will protect you from the droplets. And the mask keeps your face covered, so that if you touch the mask, you're touching the mask, not your own face. If you had droplets on your hand and you touch a mask, you're not inoculating yourself. When you get home, you've got to take that mask off. You've got to wash your hands. But consider the outside of the mask infected. So take it off, fold the inside out, get the inside inside. Don't touch the front of the mask. If you wear the mask, touch it in the front and then touch your face. You've negated some of the benefit of the mask. When you feel sick, you do have to go to the hospital. Not everybody should run to the hospital. I tell patients, you go to the hospital when you think you're getting very short of breath, when you take a breath or you're short of breath at rest, or you walk across the room or up a few steps and you get very winded, that's the time to go to the hospital. If you have an oximeter and your level falls to 92, 93, and you're feeling short of breath, that may be the time to go to the hospital. And when you go, what I want you to do is I want you to get an x-ray, because I want to see if you have pneumonia. And based on how severe that x-ray is, we're going to know what to do next. Then we may put you in a hospital. And when you go to the hospital, there are medications we can give you. Remdesivir is a new antiviral drug. It's the one that was just reported as showing benefit for reducing mortality in this disease. There's tocilizumab, which is a anti-inflammation drug that also seems to be potentially very beneficial. And then there's the whole use of ventilators and oxygen, and that's a very long discussion. But I will tell you that in our experience, patients do survive being on the ventilator. In China, the mortality rate on ventilators was thought to be about 50%. We don't know exactly what the mortality rate is right now, because all the people that are on ventilators still, we're not done treating them. And so we don't know what ultimately is going to happen. But I don't think the mortality rate of COVID on the ventilator is probably going to be anywhere near the 90% numbers that some people have been talking about. So I'm going to stop. I know I've covered a lot of ground. I've talked as quickly as I could to cover issues, but I want to leave time now for you to ask questions. So thanks for listening. And again, I know how difficult this is, and I hope that some of this information has been reassuring to you, or at least providing you knowledge. And then there's certainly more that we can talk about as we go
Thank
forward.
you.
So I'm gonna stop now. Thank you.
Thank you so much. Well, it was very reassuring, Doctor. I think it is to hear an expert tell us some things that maybe we've heard before, but it doesn't just quite translate to us. And so you actually answered quite a few of the submitted questions in your presentation, but let me sort of just jump off from a couple of things that I heard you say. People are concerned about the long-term damage that could be caused to their hearts and lungs and overall strength if they've had COVID or if they've gone through the hospital and been on a ventilator. Is there anything you could suggest? Should they keep being monitored for how long before we're confident they're 100% better?
Well, that's a great question. And I don't know that we even know the answers to that. We do know that this is a multi-system virus. I talked about the respiratory complications, but this is a virus that can cause clotting complications. People have had strokes. People have had lack of blood flow to specific areas in the heart, in the lung. They could have kidney abnormalities, probably related also to blood clotting. And so there are multiple organs that can be affected. And patients can be quite debilitated from having had COVID. In addition, when we put them on a ventilator, it's very, very difficult for patients who are very sick like this to easily synchronize with the ventilator. We give them sedation medications. We sometimes have to give them medications to paralyze them so they don't fight against the machine. And all of those medications can have long-term implications. If we give patients the paralysis, the neuromuscular blocking agents, those medications can cause muscle weakness. If we give them sedation or just the experience of being very, very sick, when they come out of it, they can be extremely tired. They can sleep a lot. They cannot be fully awake. It may take them several days or longer before all the fog clears. And sometimes they're left with some very bad experiences, very bad memories and post-traumatic stress. And we know that until all of the lung recovery and other organ recovery and neurologic and emotional recovery occurs, it may take months. And so we're developing programs at our hospital and other hospitals are developing for rehabilitation and reevaluation and recovery of patients who've had COVID. And that's going to be a process. And I don't know how long it's going to take. But I know in the past, before COVID, we had patients with similar severity of illness in the ICU, and some of those patients take easily 6 to 12 months before they're really back to normal. And so I think people think, if I get this, am I going to die? Well, that's a separate question. But if you get this and you get sick, you don't just leave the hospital and be perfectly back to normal right away. It's a process that may take months before you're completely back to normal. We assume you're going to return to normal with your lungs and your other major organs, but we have to observe people long term to know that for sure.
Right. So we know that there's lots of different kinds of symptoms and lots of different even organs that can be harmed. Several questions relating to if you've already had heart problems, a stroke, lung problems, asthma, COPD, will we see different symptoms? Should you be watching for different symptoms, and or should you be self-treating differently at home? So you've already had a history of perhaps not being the healthiest person on the planet, which we are told makes you more likely to face COVID. Is there any other special things you should be watching for?
I think I'm not sure there's an exact answer to that question. I think in general the answer is you've got to do everything you can to keep your body as healthy as possible, because recovery depends on a good functioning immune system to resist some of the secondary infections that follow this. Recovery depends on your body repairing itself, and all of that depends on good nutrition and good health status, good functioning of all your major organs and of your heart. And if you have pre-existing disease, it may slow down your recovery and it may make you more prone to other complications. But I think from the perspective of a patient who's recovering, I think you do everything to keep your health as good as possible, your nutrition as good as possible.
So there's also, and you brought it up, you talked about using an oximeter to measure your oxygen level. There's also been some stories about people who appear not to be that sick but have dramatically lower oxygenation of their in their bodies. What's the likelihood that if a runner is asymptomatic, that they should be worried about being a carrier of the disease, or even be at risk of the disease?
Well, I don't know that we know that running makes you any less susceptible. It gives you some more physiologic reserve, but I think if this virus attacks your lungs, your pre-existing general health may not be enough to protect you. Yes, as you mentioned, there was a very interesting opinion piece in the New York Times written by a doctor who said that he saw people who had very low oxygen levels and didn't look that sick. And doctors will tell us that they've had to intubate and put patients on ventilators who right before they do it are on their phone talking to their family and they look reasonably comfortable. So this virus can attack the lung, can do it pretty dramatically. I don't know if it matters if you were a runner or were highly healthy beforehand, but the reason that the oximeter may be helpful is if you're not exactly sure how sick you are and you have an oximetry level that's low, to me that's a really good warning sign to go to the hospital and be checked. And again, I think because sometimes people aren't quite as sick as we would expect with low oxygen levels, being very vigilant to early symptoms is important.
And you talked about masks when you were doing your presentation and the different kinds and the importance of the mask, even if it's just stopping spittle from getting on you. Some people talk about some of the masks they're buying making it difficult for them to breathe when they're outside. I think I've looked at some of them and it's true, they're like 4 or 5 layers of fabric and maybe a filter and maybe this. Is it okay to use a lighter mask if you're having trouble breathing through a thicker mask?
I think in general, you've got to be asking yourself, how much do you have to do whatever it is that you get short of breath doing when you wear a mask? How important is the mask? I think, again, if you understand that the major reason to wear a mask is to protect everyone around you, as long as you're wearing a mask and I'm near you and if you cough or spit, I'm not going to get it from you, I feel better. If a thinner mask might be fine for that. I don't know if a thicker mask is going to really protect you, but I know that the N95 masks are really tough to wear and wear them for long times. And so when I wear an N95 mask, I can't wear it for a prolonged period of time. So when I see people wearing N95 masks and one of the straps isn't on or they have it down around their chin, that's not valuable. Again, if you think of the mask as protecting everybody around you from you spitting on them and protecting you in case they spit on you, protecting you from taking maybe contaminated hands and touching your face, even a thin mask may be better than no mask.
Okay. So, and you touched on this, that some people are doing home therapy of certain kinds of drugs, and some of the drugs have been given, at least in nursing homes. I'm not sure about hospitals. So one person wants to know, if you were treated for COVID in a nursing home where a family member was, and they were given hydrochloroquine,
Which is,
I'm saying it wrong, right?
Hydroxychloroquine, yeah.
Thank you so much. And they believe that they have recovered and are virus-free. Are there certain things that they ought to be watched for now that they've already taken the drug? Because you voiced your concern that there are side effects.
I mean, the drug biggest side effect is cardiac, and that's relatively immediate. So if they've taken it, didn't get sick, and stopped it, they're not likely to have some long-term consequences of taking it. But again, I don't think it's a good idea to take hydroxychloroquine unless you're in the hospital, because number one, I don't think you're sick enough to justify the risk. Number two, you're not getting your cardiac monitoring. And now there are more and more reports that maybe hydroxychloroquine doesn't even work or causes side effects. So I don't think it's the cure-all that some people have believed. And I think that taking it without a clear benefit and definite risks, to me, just doesn't seem justified.
And I know we just keep learning more and more about what works and doesn't work with this disease, but based on your experience here in New York, are there best practices that we ought to be applying from other parts of the world that we haven't picked up on yet?
Well, I think we've picked up on a lot. I think that we're learning through some of the rapidly emerging data, some of the therapies that seem particularly promising. As I said, I think we always thought remdesivir might be useful. Now we finally have some data from a clinical trial that shows it probably is. We've probably learned that hydroxychloroquine is not so useful. We're trying to learn about other immune interventions. And I think it's important to think about this virus. And I'm going to show you one other graphic from my presentations. Wasn't sure if we'd get to this, but let me get to this. Okay, so I think it's important to understand that from a conceptual perspective, this virus runs in two phases. Early on, we get a viral infection, and the purpose of the body's response is to cut down the amount of virus. And at that point, when we intervene, we're trying to intervene with antiviral drugs. And that's where this drug, remdesivir, looks very helpful. So we thought hydroxychloroquine might be helpful, but we weren't really sure. But later on, as the virus starts to fade, the body develops an immune response, and that immune response can sometimes be excessive. And it's that immune response itself that begins to make us sick. And that's where the interventions happen using things like these new anti-inflammatory therapies, corticosteroids, which people may be familiar with, may be helpful, although not clear, at that later phase of the disease. And so I think that what we're learning is that at different phases of this disease, we may be wanting to intervene with different therapies. There isn't necessarily one therapy for everybody all the time. The antivirals and the antibodies may be good early. The anti-inflammatories may be better later. And those are certainly evolving best practices. The other thing that we've done in the hospital, which is, I guess I would view it as a best practice, is we realize that we've got to do a lot of things very quickly for people. And so in a normal situation, when I'm working in the ICU, I might have to intubate somebody to put them on a ventilator. I might have to put a special IV in their neck or whatever. Now we have so much of that that's necessary and at such a high volume and such a rapid rate that we've actually developed teams to do that. So we have a team of physicians that will do the intubation, a team of doctors that will put in the lines, a team of doctors who take care of the patients. When I was mentioning that you should sleep on your stomach proning, sometimes when patients are on ventilators, we prone them. And that's a very, very difficult thing to do when somebody's sedated on a ventilator and not moving. And so we need a team of people to do that. And we've set up a team just to do the proning. So those are, I won't say unique best practices, but certainly practices that have evolved in our hospital during this pandemic that I think are ideal ways to take care of patients and that we not sure everybody's doing, but I think it's a very good way to do things.
Okay, so you got to the next set of questions because people are, I think, very frightened about the idea of ever having to be put on a ventilator. And yet, if you go to the hospital with this disease, there's a chance someone is going to say you need this. So, question, you said sedated while under intubation. Somebody asked, do doctors put you in a coma, or is that just a different term for you're on a sedation medication when you're intubated?
I mean, when we sedate people, we want them to sleep. We do not want them to be aware of this. We don't want them to be fighting. We want them to wake up and maybe they don't remember what happened, which would be ideal. So yes, I mean, when they say a drug-induced coma, yes, that's what we're doing. We're sedating them to the point where they can't remember. And if they are in a state where we have to paralyze them, in other words, stop them from moving, because when they're moving, they can be fighting against the machine, and it makes it very hard to ventilate them. If we paralyze them, which we sometimes do, it's very, very crucial that they not be awake at all, because it could be terrifying for a patient to be wide awake and not able to move. So
Right.
we would not want to give you paralysis unless we know you're deeply sedated. So in that case, are we putting you in a coma? I'm not sure I would call it a coma, but it's a very deep state of sedation so that you're not having any discomfort.
And is there an average in your hospital of how long someone remains on a ventilator if you've had to make that decision to put them on one with COVID?
I think it varies a lot patient to patient. And I think in the patients who are doing extremely well, we're very happy if we get them off the ventilator after 5 to 7 days. That would be a short term. But a lot of patients are taking 2 to 3 weeks before we get them off the ventilator, and some are taking longer. We've seen people get better even after they've been on for long periods of time. So there's not a time period where we say there's no chance they're going to get better, we give up. We know that some people are going to take a longer time than others to get better.
Right. So I was just asked to mention that for a typical New Yorker right now, the only testing being provided by the city and state for to see whether you have antibodies or not is being done selectively by the city and state. It's not open to the public yet. So, but we also hear that there are some urgent care and doctor's offices that are using different kinds of tests to do post-COVID tests, and then you read they may not be legitimate. So help us understand what we should be doing or not doing.
I think, like I said, I think if you're not very, very sick and you have COVID symptoms, I'm not sure it's worth getting the test. I would treat you, assume you have COVID, and I don't think you gain much from the test.
So the newer kind, the one where they're testing the antibodies.
If you've had COVID, we might want you to be tested to make sure that 2 consecutive nasal swabs are negative before we tell you it's okay to go out in the public, in addition to that 14-day quarantine after all your symptoms are gone. Now, the antibodies aren't going to help us manage you. They're going to just tell us you've had the disease. That'll give us epidemiologic data, and it may help us when we're trying to start things up and getting people back to work. And I think that those tests are going to become much more available in the near future. I think the ones that are out there now, some are reliable, some not. I'm not urging people to go rushing for that just yet. I think in another week or two, we're going to have a lot more testing available, and we're going to know a lot more about which are the good ones and not good ones. And I don't think that a lot's going to change the next week or two by you getting or not getting a test.
That makes sense to me too. I've been worried that people are rushing in too fast when there's not enough detail yet about the different companies providing the tests. I don't want people thinking, now it's all fine, I don't have to use a mask, I'm never going to get this again, I don't have to worry about.
And we don't know. We don't know that.
Right.
We don't know yet for sure that. I mean, it's certainly better to have antibodies than not. And again, we've been through this crazy mindset. I've had this discussion with a lot of people. Everybody has spent the last 6 weeks doing everything possible to not get exposed to this virus. Those people ought to not have antibodies. Now, all of a sudden, what everybody wants is antibodies. So
right.
What I guess everybody really wants is they want to know that they had this disease, but they never got sick from it. And that may be the reality for a lot of people, but I don't think any of us want to tempt fate and expose ourselves just to get antibodies because we might end up getting a more severe infection. And I think that ultimately what's going to protect a lot of us is when many people have antibodies, there's a concept of herd immunity. When maybe 40, 50, we're not sure, 60% of the population have antibodies, the virus has a much harder time sticking around if most people have antibodies to it. And that begins to protect the rest of us. So there's got to be a certain level of antibodies to protect all of us. And as I'm sure many of you have heard, that's been the philosophy in Sweden, that they seem to be counting on herd immunity to protect everybody. So there's a lot of different ideas. I don't think we have all the answers yet. And I think we're getting to a point where if 25% of New Yorkers have had antibodies, then maybe we're starting to get up to a point where those people may be able to safely go back to work. But it makes it safer for more of us as well. Right.
And what we all really want is a vaccine that we can take a shot and then not have to worry about getting COVID. So why does everyone say it takes 18 months before it's realistic?
18 months would be really fast, because you've got to realize the steps involved here. You've got to develop the candidate vaccine. You've got to test it in animals to see if it's even working and if it's safe. Then you've got to do phase 1 trials where you test it in a small number of humans to make sure it's safe. Then you do phase 2 where you do a larger number of patients and, again, make sure you can find the right dose, find the right safety, see what the effects are, and then use that information to design a phase 3 trial where you give it in large quantities to large numbers of people and measure what you've identified to be the ideal endpoint at the right dose to see if it really works. And then you've got to get governmental approval and manufacturing. And so to do all of that, knowing that not every vaccine is going to work, it may get partly down that line and then run into problems. And I think everybody agrees that the best way to get a vaccine is to have multiple companies working on it at the same time, because then it just becomes a numbers game. Not only do you get the time period maybe shortened, but statistically you get a greater likelihood that one of them is going to work when a lot of people are developing them.
Right. So people have other medical issues, even though COVID's come and taken over our lives and our world and everything we do, and we wake up until we go to bed at night. Suppose we have other medical needs. Should we still be trying to see our doctors? Should we be putting things off that, if let's say we've had heart issues and we have a standard every 3 months to go back to see the doctor, or we have COPD and we are standard to see you. Should we be still trying to go have those doctor's appointments? How do we decide what the right answer is?
That is a really key question. And I think that's something we're all worried about. We've made COVID by necessity our number one priority, but we know there are patients with very serious medical problems. We're letting them ride because either we don't have the facilities to take care of them right now because they're all devoted to COVID patients, or they're afraid unnecessarily, I might add, of coming to the hospital to get those things taken care of. We see people who have lung cancer. There are people who have suspicious findings on their x-rays. How long should we allow that to sit there? That's one example. Having serious heart problems, having a breast mass. There are a lot of real medical problems that are getting delayed. And although we can do some triaging via video visits, we can't do therapy or evaluation for very serious problems in everybody by video. So we are going to have some face-to-face visits. We're going to have some testing and treatments in hospitals for some of these non-COVID illnesses. And I think we're worried that we're waiting too long. So I think we're trying to find that right balance between waiting and getting things started up, and getting things started up in a way that doesn't put anybody at risk.
Agreed. And I've just looked at my time. It is 7:55, which
wow.
I know.
Well, we just started.
You and I joked earlier that the hour would go by so quickly. So I want to thank our audience who we can't see, they can only see us, but I do want to thank them for tuning in and thank them for all the questions. We did not get through everyone's questions, but between what you presented so well in your original introductory presentation and my follow-up questions, I think we got to most of the questions. Um, Again, you were kind enough to show your email address. I just going to tell everyone out there, I suspect this doctor is going to be too busy to be able to answer all our questions,
Right.
but you can reach out to my office, and we do try to respond to everyone and get them other resources they might be able to use. I want to remind everyone that here in Manhattan, most of our hospitals and actually most of our insurance plans nowadays are offering telemedicine options. So even if your personal doctor can't do a telemedicine visit with you immediately, most of the major medical centers are offering sort of a centralized telemedicine system where you can reach out and talk to someone almost any time, day or night, with questions. Again, as the doctor said, we're not encouraging people to rush to an ER unless they really think this is what they have to do from a health perspective. No, don't go to your hospital waiting to go thinking you're going to get a test for COVID. They're not probably going to give you a test at the ER, but you are going to increase your chances of ending up with COVID by showing up in a hospital unnecessarily. But don't think there aren't ways for you to access health care and health information, because so many of us are so highly attuned to communicating now with people over the phone, over Zooms like this. I actually have a doctor's appointment over Zoom in a couple of days, because when I checked to see whether I should cancel, they said, want to try it over the Zoom? I said, okay, I'm prepared. So we'll see about that. We are thanking you again, Dr. Niederman, for taking the time to be with us tonight. And I want to mention our next virtual town hall will take place Thursday, May 7th. And the topic then, and this becomes more relevant every day we're trapped in our houses, mental health. How do you deal with mental health issues when you're all living on top of each other 24/7? We are absolutely seeing growing concerns. We have an excellent presenter for that evening, Dr. Lisa, she's not a doctor, Lisa First, Assistant Vice President, the Center for Policy, Advocacy, and Education at some group now known as Vibrant Emotional Health. I've heard Lisa present. She's excellent. We'll be giving you more details about that if you're on my email list, and you'll be able to pre-register as you did for this. If you heard about this, got online, and joined us but don't know, you can get daily updates from my office. Please go to www.lizkrueger.com, and you'll see a website where at the top right you can enter your email address, and we will put you on the list. Again, whether you live in my district or not, everyone's welcome to that information. Again, I want all of you to stay well, stay safe, wear face covering, and stay at least 6 feet apart from others when you go outside. Thank you again.
One other thing I want to say is, if you do want to get more information, through Weill Cornell Medicine, we made a video that has a lot of this information in it. And so the way you can find it is just go to Google, type in my name, just put in Weill Cornell COVID video, and you should be able to find it. And a lot of this information is there as well. So thank you again for your listening tonight. Thank you.
Thank you, everyone. Good night.